ladies and gentlemen, good afternoon. Bom dia. Obrigado por me convidar. Eu muito bom estar no Brasil. That's all the Portuguese I know, I'm sorry. It's my pleasure to be here this afternoon to speak on the topic of prevention and treatment of hypotension during spinal anesthesia for caesarean delivery. Very briefly, I have no disclosures to make with respect to this lecture. So here is an outline of my talk this afternoon. I'm going to begin by discussing the incidence of hypotension in obstetric patients. Secondly, I'm going to talk about the past versus the present in the way that we manage this problem. Thirdly, I'm going to spend a little bit more time talking on the topic of vasopressors. And finally and fourthly, I'm going to talk about some recent developments in this area. So the incidence of hypotension during spinal anesthesia in obstetrics, of course, does vary according to the definition that we use. But we know that it is especially high with spinal anesthesia, in which it's known to occur in about 50 to 80% of cases, or even greater. But the incidence, of course, is dose dependent. It depends on the dose in our spinal anesthetic. And we can show this by imagining the dose that is required for an adequate spinal block, which probably approximates a normal curve, as you can see here. Now, for those of us who normally like to perform single-shot spinal anesthesia, most of us would normally choose a dose on the right-hand side of the curve as shown here, really with the objective of trying to minimize this area shaded in blue, which would represent those patients in whom your block is inadequate. However, by choosing a dose on the right side, we are effectively overdosing those patients whose dose requirement is on the left-hand side. And it's these patients who usually will suffer the most severe hypotension. Now, one common way of trying to adjust for this is to choose a dose more in the middle of this curve. And we can do that by using, of course, the combined spinal epidural technique with a smaller dose, knowing that we have an epidural catheter to top up those patients in whom your block is not effective. And there have been a number of different studies looking at this. Here are some examples. The one example I will choose is the study that comes from Korea by Choi and colleagues. And you can see here they compared on the left-hand side a low-dose CSE technique, compared with the right-hand side a higher dose spinal, and you can see comparing the red with the blue that the incidence of hypotension is much lower if you use a lower dose in your spinal. So that's a very easy technique that we can often use, and we use this technique particularly in patients with heart disease. So that is a brief talk about the incidence of hypotension. I want now to talk a little bit about the past versus the present in the way we manage this problem. Now, in the past, the focus really was mainly on the effects of our spinal on venous return. It was thought that vasodilation occurs from our spinal, which then combines with the effects of aortocabal compression, and this then leads to a decrease in the venous return. Now, this decrease in venous return results in a decrease in the cardiac filling, which results then in a decrease in cardiac output. And in the past, this was thought to be the main contributor to the hypotension that is seen. So because of this, there was the introduction of a number of different, what I call mechanical methods of trying to maintain this cardiac filling. And these were strategies such as the use of left lateral uterine displacement and the use of intravenous fluids. And these are techniques that I use, you probably use in your everyday practice. The one that I will talk about briefly is the use of intravenous fluids, which I think that many of us use during our spinal anesthetics. When we think about the IV fluids, we can think about both the type of fluid as well as the timing of your administration. In terms of the type, we can give either a crystalloid or a colloid. And in terms of timing, we can give this fluid before the spinal, pre-hydration or preload, or immediately after the spinal, which is called co-hydration or co-load. And so when we imagine the different combinations of this, it's now very well accepted that the use of crystalloids for pre-hydration or preload really has very little, if any, effect on the incidence of hypotension. And most of us now are not using crystalloid preload at all. There is a reasonable amount of evidence that if you give your crystalloid as co-hydration or co-load, so start the fluid immediately after your spinal, this is a little more effective. If you choose to use a colloid, which I do not in my normal practice, but if you do, because of the longer intravascular half-life of our colloids, it doesn't seem to matter if you give these as pre-hydration or as co-hydration. They seem to be equally effective. However, despite whichever type of fluid that you use, it's known that these mechanical methods of trying to prevent hypotension are not very effective. They have very limited effect in preventing hypotension. And the reason for this is that the premise, the thought that cardiac output decreases, is probably not true. And there have been a number of studies now that have shown that in fact in most cases the cardiac output increases rather than decreases. And here are some data from an interesting study from a Norwegian group. So in most cases, if you don't use a prophylactic vasopressor, the cardiac output will go up. So we know that in the past there was a focus on venous return, which led to the use of mechanical methods and IV fluids, but as I've mentioned, these are now thought to be not very effective. So in the present, and our current way of thinking, there has been more of a change towards a focus on the systemic vascular resistance changes. It is now appreciated, of course, that the same vasodilation occurs, but this is associated with or interacts with an increased dependence on sympathetic tone which occurs in pregnant patients. This leads to marked arteriolar vasodilatation in these patients, which decreases the systemic vascular resistance. And it's this decrease in the SVR that is thought now to be really the main contributor to hypotension rather than a change in cardiac output, which of course makes good physiological sense. And because of this, the emphasis really has changed away from the use of fluids, more towards the use of vasopressors, which is a subject that I want to spend a little more time talking about in some detail. Now, when we consider the use of vasopressors, we can think of a number of different aspects. Firstly, there is the choice of drug that we will use. Secondly, there is the method of administration. And thirdly, there are some important safety factors or issues that we have to consider. Now, when we think about the choice of vasopressors, in fact, there is a large number of different drugs that have been used around the world. I'm sorry, I'm not aware of what drugs are used more predominantly in Brazil. I know from my good friend Jose Carvalho that you use metronidazole a bit, which I think is a very good drug. However, around the world internationally, the drug that is most widely used is this drug called phenylephrine. And certainly for many years, this has been my personal, or my department's personal choice, first line drug. Now, there are many reasons why we should consider phenylephrine or similar drugs as our first-line drugs, especially compared with the old favorite, which used to be ephedrine or ephedrine. The most important reason simply is because phenylephrine is effective. This is because we know that it is an alpha agonist drug that has direct vasoconstrictor effects. It has a fast onset, a short duration, and is easy to titrate, all features which we like in an anesthetic drug. The second reason is that we know now that it is associated with a very low incidence of fetal acidosis, even when used in relatively large doses. And the probable reason for this, as shown in this study that my group published a number of years ago, is because phenylephrine does cross the placenta much less than some other drugs, particularly ephedrine. So in this slide, I depict the placental transfer of the two different vasopressors. And you can see, comparing phenylephrine in red versus ephedrine in blue, that the ratio, the umbilical venous to maternal arterial ratio, which indicates the amount of placental transfer, is much less with phenylephrine in red compared with ephedrine in blue, shown quite clearly here. The second issue I want to talk about is the method by which we give these drugs. How is the best way to administer your vasopressor? There are two issues. The first is the timing of your administration, and the second is the actual method by which you give the drug. In terms of timing, I am a firm believer that the most effective management is to start your administration immediately or soon after giving your intrathecal injection. Don't wait, start it early. In other words, there should be a focus on preventing rather than treating your hypotension. If you start giving your vasopressor early, you will find that the incidence, particularly of nausea in your patients, will be much less. So I think this is a very important point. And I start my administration immediately after my spinal without even measuring the blood pressure. The second issue is that should we be using a bolus or an infusion for our drugs? And in fact, you can use either. Both of these methods are effective, and it depends what you are more familiar with. With the bolus technique, intermittent boluses are very simple and easy. In our practice, we tend to use infusions because we find that they are more convenient. We have many syringe pumps, easy to teach, and the blood pressure is a little more stable. But either technique can be used. It's just important that you start to give the drug early. As an example, this was an interesting study that was published from a group from Beirut in Lebanon in anesthesia analgesia, where they compared a variable rate phenylephrine infusion with rescue phenylephrine boluses, published in 2014. And they found that using an infusion, there was less hypotension, although at the expense of a slightly increased incidence of hypertension. But there was less nausea and vomiting when an infusion was used, and importantly, fewer physician interventions, so less work. So there is some evidence that infusions are at least a convenient method to use. There are, of course, a number of important safety considerations. And some of the things that we have to think about are bradycardia that may occur with our vasopressor, a decrease or an associated decrease in cardiac output, and their use in higher risk cases and emergencies. Bradycardia is very important because for those of you who have used phenylephrine in larger doses, we know that this occurs very frequently, and it's probably thought to occur because of a baroreceptor-mediated reflex. However, the bradycardia is almost always transient because this is a short-acting drug, and the heart rate will rise again as soon as your vasopressor is stopped. This is important because I think you need to be very, very, very careful with the use of anticholinergics. And I would suggest that giving a drug like glycopyrrolate or atropine, I would never give these at the same time as phenylephrine if there is a bradycardia because you run the risk of the blood pressure going very, very high. So please do be very careful if you are considering using an anticholinergic drug. The importance of the bradycardia is that many studies have shown that high-dose phenylephrine, when it causes a bradycardia, this is associated with a decrease in the cardiac output. However, the significance of this in our low-risk elective cases is uncertain, as indicated by usually quite normal umbilical cord gases. However, there is some concern there, particularly if we are looking at the higher risk and emergency cases, because we have to remember that most, if not all, of the research has been done on low-risk electives. There is not much information on these important high-risk cases, and I mean cases such as those with hypertensive disease, chronic or acute placental insufficiency, or non-reassuring fetal heart rates. There are limited data available for these cases, so I think it is prudent to use perhaps less aggressive dosing. I'm very aggressive with elective cases, less aggressive with high-risk cases. Now, the fourth area I want to talk about briefly are some of the recent developments in this area, and my department is very active in research in this area. What's in store in the future? And the two areas that I want to talk about are firstly the use of automated computer control, and second are newer or alternative vasopressors. Now, my department has some interest in the use of what we call closed-loop feedback computer-controlled infusions. And here are two papers that we have published in the recent literature looking at this technique. What this involved is a closed-loop circuit. So we have our patient, as you see in green, who is connected to our anesthesia machine for monitoring. The monitoring data are downloaded by a laptop that runs a program which sends a control signal to the syringe pump, which automatically then controls the rate of phenylephrine. And this goes around in a continuous automatic cycle without any manual control. Without going into too much mathematics, the algorithm we used is called a PID controller, proportional integral derivative, which looks at things like error, past changes, and rates of change, but I won't go into too much detail with this. Here is a screenshot from our computer program. You can see in this particular patient, our target was a systolic blood pressure of 114. The actual blood pressure was 109 systolic, and so the computer is running the infusion, in this case at 60 mils per hour, but this will vary after every blood pressure recording. In that particular patient, here is a screenshot of our monitoring program, and you can see the blood pressure control is not perfect, but it's not bad. Oops. I'm sorry. It's not bad, right? But this is completely automatic without any interaction by me. Here is a photograph of our setup. You can see we have a couple of computers, we have a syringe pump, and lots of wires. Easy for me to trip over. So because of this mess, we have looked at trying to simplify it. One thing we have done is move from a wired to a wireless system, and secondly, from a laptop to a handheld system. And in fact, one of my junior staff has written an Android app, and so although we're not using it commercially yet, I do have the ability to control the blood pressure with one touch of my smartphone. So it's fun. It's a bit geeky. My friends in Singapore are also looking at similar technology, where they are using continuous blood pressure monitors with a finger probe and using multiple drugs according to the heart rate changes. So there is a lot of scope of different types of automating this control. The final subject that I wish to talk about briefly is the consideration of alternative or newer or different vasopressor agents. Let's think about what is ideal. I think this is ideal in Brazil. The ideal should be fast and it should be effective. But also, the ideal should be cheap. It should be titratable It should not cause bradycardia. It should preserve the cardiac output and, importantly, preserve the uterine blood flow. Let's consider what the ideal vasopressor might be. With phenylephrine, the drug we mostly use at the moment, we have a drug that is a very potent alpha agonist. But it's important to realize that phenylephrine has no beta activity. And this is the reason why we see this non-compensated bradycardia with phenylephrine. I believe that the ideal drug, the ideal alternative drug, would possess the same alpha activity as phenylephrine, but also possess a little bit of beta activity to try and prevent the bradycardia. Now, some of you may be already imagining which drug I'm going to talk about. And the drug that I think suits this pattern most clearly is norepinephrine, or noradrenaline, as we call it in my country. Noradrenaline has the same alpha activity as phenylephrine, but a little bit of beta activity. And last year we published in Anestesiologia a randomized double-blinded comparison of phenylephrine and norepinephrine. And I'd like to show you some of the results of this study. Noradrenaline, or norepinephrine, of course, is a very readily available, it's an old drug. It's familiar to most of us anesthesiologists, especially we who have worked in the intensive care unit. It's a drug we know that is easy to titrate. My colleagues in ICU prefer noradrenaline to phenylephrine because they know that it preserves the cardiac output better in ICU in shocked patients. And importantly, certainly where I come from, is cheaper than phenylephrine, which is very important. So in our study, we looked at elective spinal caesarean section patients. We used our computer-controlled system to deliver either, as you see on the left in blue, phenylephrine 100 micrograms per mil, or on the right, norepinephrine 5 micrograms per mil. And here are some of the results. The systolic blood pressure, as you can see for the two groups, was similar between the drugs. They're both alpha agonists, both very good at keeping the blood pressure, as you see, very stable. However, when we look at the heart rate, when you compare the white circles, which is norepinephrine, with the black circles, which is phenylephrine, you can see that the heart rate was maintained much more closely to baseline. It was greater with norepinephrine compared with phenylephrine. And this was associated with greater cardiac output in the norepinephrine group compared with the phenylephrine. What about the babies? Well, of course, we measured the umbilical cord gases, and in fact, we found no significant difference in pH. In fact, there was a slight difference in that the umbilical venous pH and oxygen content were higher or better in the norepinephrine group. However, this was not a primary outcome of the study, and so this really needs to be confirmed. But certainly the blood gases were not worse. If anything, they were a little bit better, but not worse in the norepinephrine group. And so our conclusion from this was that norepinephrine may be an ideal obstetric vasopressor. However, more work is required, and I'm happy to say that there is more work being done in my unit and by my good friend Jose Cavallo in Mount Sinai in Toronto, is doing some excellent work there, and I think this is an exciting drug that we will see more of in the future. In my unit, in my practice, in fact, I have been using norepinephrine in all of my cases for about a year now, and the concentration that we use currently is 6 micrograms per mil, which is probably a little closer to phenylephrine 100. And of course, you must appreciate that this is a very dilute solution, much more dilute than we use in ICU. In intensive care, we are mainly using a minimum of 80 micrograms per mil, and then even much greater. This is a very dilute solution. So, ladies and gentlemen, my key points from my talk this afternoon. I've told you that hypotension, of course, is common, particularly with spinal anesthetics. The mechanism is now thought to be more related to the arterial circulation than the venous circulation, which explains why our mechanical methods, like fluids, really have limited use. And of course, our use of vasopressors are now accepted as the most important factor, the mainstay. Phenylephrine is currently around the world the most commonly recommended vasopressor because mainly it has greater efficacy compared with ephedrine and less placental transfer compared with ephedrine, and therefore less fetal acidosis. If you're going to use phenylephrine, I recommend you start early, immediately after your spinal anesthetic. You can use an infusion or a bolus, but we much prefer infusions because of convenience. Bradycardia may be seen. Just stop the phenylephrine. Be very careful about using anticholinergics, which I never use. I've explained that automated computer-controlled methods are in development, and I think that this is the way of the future, possibly with handheld and wireless devices, which are fun. Norepinephrine is an old new alternative, which does have the advantage of maintaining the heart rate and cardiac output better, and it's cheaper. However, I think that more work is required before we can universally recommend this drug, and more work, in fact, is underway. So thank you, obrigado. I thank you very much for your time and attention.